Hey guys, welcome to Podiatry Practice Mastery. Down here, I am recording a video, and this will be an audio for the podcast. But what I want to go over today, I got a question from one of the doctors that's part of the Practice Mastery Academy, specifically about shockwave. So he does shockwave. He wasn't having the best success with shockwave, with having patients kind of do the shockwave. He wasn't really seeing the improvement that he was wanting with it. So I want to kind of do a deep dive on shockwave for plantar fasciitis and Achilles tendonitis. Not just shockwave though, because I don't think you can't just do shockwave. Everything has to be part of everything else that we do. So that's why I want to spend some time kind of going over this. The goal would be after this, you could understand kind of my protocol. I'm not saying it's the best, but it's just something that works for me. You might want to consider it for yourself. So I am going to start with sharing my screen. And what you're going to see, first of all, is something called my patient presentation. So if you haven't seen these before, I would recommend you kind of taking a look at them. You can go to patientpresentations.com to take a look at them. So here we can see my screen here. Okay. So to get to this, you would go to patientpresentations.com, and then you would click on plantar fasciitis if you're going to deal with that. The heel pain, if you're talking about Haglund's, or if you're going to talk about Achilles tendonitis. They're all kind of similar. What you're going to find is it's going to open up something like this. What this is a Google Slides in full format mode. And so you can use this. This isn't specific to me. This is something that I put together, but you can use it. And I tried to keep it like non-DONS, like it doesn't have my practice's information on here, so everyone can use it. There is a little laser pointer if you wanted to use this as you're explaining it to patients. So what I tend to do is I just keep it on my desktop, this patient presentations link right here. And then when a patient comes in, I pick the right one and I go through it. This is the exact same thing I do. So I'm going to go through a little bit about how I explain plantar fasciitis, then we're going to get into how I use the shockwave. You're also going to notice something called the treatment sheet, and I'm going to get to that at the end. I show this at the end. It's the actual treatment sheet that I print out for patients, and it goes over all the treatment options. This one is specific to me only because I do use it, and so I print it out, but you could certainly, it's in preview mode. So what you can do is you could download this. If you just remove preview and hit copy, and it'll copy a Google Doc for you to do it if you're kind of high tech. If you need help, just let me know. Okay. All of these as well are within the Practice Mastery Academy. So let's do a deep dive. So plantar fasciitis, I always explain to patients this is where their pain is. I always ask them how long they've had symptoms. I ask them if they've seen other providers, because many times I'm seeing them after they've seen someone else. I'm going to go over how it impacts their life and why they want treatment now. So these are just, I think, are important questions. I do this for everything that I do. Specifically, this is the anatomy slide that I go over. So for Achilles tendonitis, I'm going to talk about how it pulls in the back. I'll talk about a spur forming because of the pull. If there's a Haglund's, I'll kind of go over that on the x-ray. I'll show them the x-ray. I'm also going to be watching them walk. And then on the plantar fascia, I'm going to explain that it's white. Both the Achilles and the fascia are white. This one pulls this way and it makes this one tighter. And if it's white, it doesn't have the best blood supply and circulation. So we have some treatments that are going to help get the blood supply back to the area, both areas, and that's going to be the shockwave. I really emphasize the importance of it being white, not having the best blood supply. I also emphasize the importance of the back of the calf being tight, because that's going to focus on how all of them get the foam rollers and stuff like that in the office. Then I go over this. It shows ultrasound. So I tend to do the ultrasound in the second visit. I'll explain what I exactly do for visits. Actually, I'll start and explain the first visit. So the first visit, my patients tend to get x-rays. They're going to get an anti-inflammatory, icing, contrast baths. They're going to get foam rolling, a morning, a night splint, towel stretch. They're going to get shoe recommendations. They're going to get UFOs, foam sandals, and patient education information. That's the first visit. Then when they come back in 2 weeks, as I explained here, I say, when I see you back, if you're not getting better, we're going to do an ultrasound. So here's an example of the ultrasound probe. We're going to look at the thickness of the fascia, and I can compare the right foot to the left foot, or your symptomatic to the asymptomatic foot. We're going to look at that. And if it's a lot thicker, that shows that there's abnormality or inflammation in the fascia. So in Massachusetts, ultrasound is not usually covered except for like Medicare. And so I just say it's $100 for the ultrasound, and that's as many as I want to do. I could do one today. I could do one in 3 weeks. I could repeat it, and I only charge them one time. If I'm doing ultrasound guided cortisone only without the ultrasound read, I tend to charge them $50 to do the ultrasound guided cortisone injections. And that's how all of my patients get ultrasounds. I'll talk about a spur a little bit, and then so the other two presentations on Achilles tendonitis and Haglund's are pretty similar, so they're kind of analogous to this one. So then I go into this. This is my treatment evaluator. This is the different types of treatments, and I always preface it by saying, this is an effectiveness scale. Some treatments are more effective, others are least effective. We want to focus on reducing pain, reducing tightness, and reducing stress through the foot. Most of my patients try the stuff underneath the yellow line before they come and see me. So they've tried this before, and they'll usually agree. They've tried anti-inflammatories, icing, topical stuff, stretching, over-the-counter arch supports, taping. And then at this time, this is where I'll get out on the first visit my treatment sheet, and I'll say, okay, so for the first visit, we're going to start with these things, but we may have to do shockwave in the future. Okay. And I'll briefly preface the shockwave. If you want to see what shockwave is, you just click the link and it goes to the shockwave page talking about shockwave. I'll explain how it injures it with sound waves and hits the area. I'll kind of talk about the process, which is the ultrasound. That's always important. The 3 to 6 sessions, a 6-week follow-up, and things like that. And then to go backwards with this, the way you do it is you click the back button. So you have to click back. Okay. Otherwise, it doesn't work as slick. So you click the back button. I don't usually go over the amnio at the first visit. They may or may not do orthotics. I'm not really talking about the AFO. So in the first visit specifically, I'll check these boxes. So I'll put their diagnosis down. I'm usually doing a 2-week follow-up. They're going to do x-ray, like I mentioned before. Usually I do meloxicam. That just works good in my hands because it's once a day dosing. They're going to get icing, contrast VAS. I'll explain that. It's written right here. Foam rolling. They're going to get stretching, towel stretch in the morning. They're going to get shoe recommendations. And then I'm going to ask them to read this. Watch this video. This is a patient education video. You can use your own QR code to your own video if you want, or you can use mine. And then that's the first visit. When they come back the second visit, let's say they're not better. They're already prefaced to do the ultrasound. So what I do with this is I actually circle the ultrasound and I circle the shockwave. So I check what I do and I circle what I'm going to do next visit. And so when they come back, they're already aware, and the ultrasound's already in the room. So when the ultrasound's in the room, I will show them this slide again about the ultrasound, explain the difference, and then I'll do the ultrasound and I'll show them one side to the other. Many times patients like to take pictures with their phone. I'll have them take a picture, explain the difference, explain why it's thickened, and that thickness that tends to work better with the shockwave. I'll explain the way I explain it is that the cortisone might make it feel better temporarily, but it doesn't usually heal the tissue. The way to heal the tissue is with the shockwave. And if I see within the ultrasound, like there's a lot of thickness, but some black areas, some micro tears or some tears in the fascia, that's where I'm going to recommend the amnio injection. So after I do the ultrasound, show it's thicker on one side compared to the other, they understand the importance of the shockwave. What I'll do is I'll pick this thing up again and I'll say, okay, we're going to stop the anti-inflammatories. We're going to set up 3 sessions of shockwave. If they've had pain for over 6 months, I'll usually do 6, but I always start with 3 with everyone. I do three sessions of shockwave. So I set up three appointments. I remind them no anti-inflammatories. I also will schedule at this day the physical therapy as well to start 3 after they finish the 3rd session. And then I'll also, going back the first visit, the reason I do anti-inflammatories is because it moves me up to a level 4 visit usually because of the medication management. And then in the second visit, physical therapy, it's usually going to be like a level 3 visit. And then they're going to do the shockwaves. And then the shockwaves, there's no office visit the days of the shockwave, the 3 shockwaves. Usually at the last shockwave, I might do an office visit if I go into more detail. And I guess while I'm here, I'll explain that. So, let me explain what I mean by that. So I made something up here about my for my last visit of Shockwave, because I was struggling. I was doing the 3 Shockwaves, and I wanted the last one to be an office visit, but I wasn't really going over things enough. So that's why I made the CMP treatment sheets. So if you notice here, there's going to be, let me see here, Shockwave last visit letter. And so this is one I go over with patients their last visit. I also have a similar one that I do for nail fungus that really improves the amount of laser, not laser, but the steri shoe and the spray. If you want me to do that, just send me an email and I'll do that in another video. But this talks about the last visit. So after the 3rd or 5th, I talk about it speeds up healing by 50%. It's 82% effective. It will continue to work over 2 to 6 months. They gradually start to have more good days than bad days. The improvement slowly happens because your body is healing itself. I'll talk about what to continue, and I'll talk about the next steps if they're not getting better. Okay, and I'll put that in there. So this is something important, I think, for the last visit. When I go over these things in detail, then I feel confident I can do a level 3 established patient at that last Shockwave appointment, because I'm going into more detail. They're also going to be starting physical therapy. I know other people do physical therapy the last visit. The problem is around here, it takes about 3 weeks to get in. And that's why I don't do it the last Shockwave. I do it on the other one. Okay. So that's kind of how we do that. Okay. Let's go back to this here. So the treatment sheet, they're going to get Shockwave 3 sessions. So let's go a little bit into Shockwave. I wrote down some of my my settings on the Shockwave just to help you out. So for the settings, what I do is I usually do, only because it makes a lot more noise, I'll tend to do the focused Shockwave first, and then I'll do the radial. I have both focused and radial. If I'm in my one office where I only have to do radial, then I'll do radial only. Okay. The way we do it in our office is for the combo radio and focus, we do $250 per session. If it's and they pay as they go. And then if I only do radial, it's 200, or if I only do focused, it's 200. Sometimes I only do focused if it's like bone marrow edema or a fracture or something else like that. But usually I'm doing combo. So the way I do it for combo, if I'm doing focused first, so focused and radial, I do 2,000 pulses each. Okay. Sometimes I'll do a little bit more if I'm going to do one alone, but 2,000 and 2,000. Okay. So for focused, I start out at 0.2. And I go up to 0.35 if I can into the tissue. So I'll gradually titrate myself up. I'll start at 0.2, and according to tolerance, I'll build it up. I'm usually doing it on the most painful area. They say you're supposed to work an area of like a quarter or a $50 area with the focused. Okay. And then I do 8 hertz. Okay, 8 hertz. That's kind of how I do it with focused. That one tends to be painful. I might have to titrate it down if they're in too much pain. And then if they're in a lot of pain, I might do the radial first to kind of get some blunting of the pain first. Okay. And then what I'll do for the radial is I'll do from 2.0 to 3.5. I'm usually using the gold tip, except when I'm doing a Haglund's or an insertional Achilles, then I'll use the cobalt tip. So the gold tip's the harder, smaller, cobalt's a little bit bigger. But because the Haglund's or insertional Achilles tends to hurt a lot, so I'm going to have to either lower down the hertz, or I'm sorry, increase the hertz, because the quicker it goes, the less it hurts. No pun intended. And then the slower it goes, the more it hurts. And so the cobalt hurts less than the gold one that we have, the ceramic one. So I go from 2 to 3.5 if I can get all the way up to 3.5 to 4, 2,000 pulses, and I'll start out really fast. I might start out at 19. So what they're recommending now is doing it faster. So I'll do it faster because it doesn't hurt as much. And then I'll do, let's say 19 hertz for like 500. Then I'll switch it down to 12 for another 500. Then I'll go down to maybe like 9 for the last 1,000 or the last 500, depending on the pain. And as I'm going down in the hertz, I'm increasing it up to, if I can get it all the way up to 3.5. Okay. I used to do just 9 all the time, or go 12 for 500 and then 9 for 1,500 or 2,000, because it's more hitting, but that one hurts a lot. And I'm kind of getting the same results with both. And so the other question the other doctor had was, how do I do amnio? So with amnio, if I do see a tear in both the Achilles if I see like an effusion within the Achilles or at the insertion or within the plantar fascia, I'll always offer this to them. So the way I explain it to patients is I'm going to do 3 sessions for $750 of the shockwave. And then if you want to do the amnio, it's $1,500, and I usually put them in a boot. I usually do the amnio at the second visit. So I will do amnio, for example, like a plantar plate injury on the second med head. I'll do it for plantar fasciitis. I'll do it for these. I do not do a ton. Maybe last year I think I did the most in our practice, maybe 15. So maybe 1 a month, a little bit over 1 a month. So it's not a lot of amnio because I use the right ViaFlow and it's very expensive. If I did something cheaper, it would probably be easier to do more. But that's the one that I do. And those are kind of my settings for the shockwave. So kind of going back, I'm going to share my screen once again, just to kind of finish up this explanation here. So with this treatment sheet, this is kind of what I use for patients when they come into the office. So the second visit, if I'm going to do amnio, I'll hit shockwave, I'll check that, and I'll check amnio. And then when I schedule, I'll schedule 3 sessions, and I'll usually say at the second one, I'll do the amnio. They'll continue to icing, contrast baths, the physical therapy will be set up. They'll continue these other things in the shoes, and a lot of times they'll do orthotics if they have a lot of pronation or things like that in their foot. And then at the last one, like I said, I use this other letter that they have. Just give me 1 sec. I'll be right there. Thank you. So that's how I do it for plantar fascia. A couple other things I want to show you in the presentation. If you want to show shockwave, you can show it. You can use this. This is the process I like to use to explain. Once again, if you go backward, you can't just go back, because if you go back, it'll show the focused and radial. It kind of explains how they work. So one will go right here. If you go forward or back with your mouse, you can do that. It has some shockwave questions. But then the other thing is I have a lot of other things in these slides. So if you start going back, you have to go through everything. I'm just kind of showing you. So I do on purpose, I do a black slide when I'm done. So it's a long presentation. So usually what happens is what you saw was this. This is the last slide. If you go here, it blackens out, but there are other slides there. So I have like a long and a short presentation. The long one is usually for when I'm like recording a video. Okay, so if you want to go there, basically click amnio, show them around, and then go backward. Show them shockwave, okay, and then go backward up there. If you want to talk about orthotics, you can show orthotics. It has some information about orthotics. You can go back and back and back. And then if you want to show the arrow spring, I don't do a lot of arrow springs, but occasionally I do with ones that aren't getting better or people that have been wearing a walking boot for a long time. I'll do the offloading AFL. Okay, I do not have links to everything, but in that presentation there are links. So if you want to make your own, include links to icing and contrast baths or night splints, you can do that. But the problem is you can only talk about so many things and you only have so much time. So there is an analogous presentation about Haglund's, about Achilles, with similar treatment sheets within my patient presentations. Okay, so that was a long haul. If you are listening to the audio of this, you can see the video on my YouTube. It'll be up there. I'm going to put the video up there for you so you can watch that. Not sure what it's going to be called yet. Probably is going to be something like explanation of how to use treatment sheets for plantar fasciitis and Achilles tendonitis. Okay. Once again, if you guys found this beneficial, great. Put a comment underneath this video or this podcast. If you want to learn more, go to Practice Mastery, Podiatry Practice Mastery. My academy has everything, and you can have access to ask me questions. Happy to help out. Hope this was helpful.